Okay, so welcome everybody. It's great to have you here for the second NCRED webinar of 2024. We'll be addressing the topic methamphetamine use, working with family and friends. My name is Dora Karavasilis and I'm the Knowledge Translation Lead at NCRED. Before I go any further, I'd like to acknowledge that I'm coming to you from Dharawal country in my hometown of Wollongong, and I'd like to acknowledge the traditional owners of wherever you're coming from too, and acknowledge that sovereignty was never ceded. Family and friends and partner and support systems can be a really crucial ingredient in supporting a person to make changes to their substance use. And most of the calls received by national AOD helplines are from families, friends, or concerned loved ones looking for advice, help, and support. However, there's limited research exploring the needs and what works and what doesn't work in supporting people to navigate substance use or dependence of somebody that they care about. This includes methamphetamine, where the incidence in Australia is higher than other countries and around the world, and the treatment access gap is estimated to be upwards of 13 years. Today, we're going to explore this topic, taking a deep dive into methamphetamine, working with family and friends. We're going to outline the state of theory and practice in family and friends alcohol and other drugs work for methamphetamine. We're going to highlight the differences between working with methamphetamine compared with other drugs, and the unique challenges when working with families and friends of people who use it. And we're going to discuss the way forward and how to support the sector to support family and friends of people who use methamphetamine. The webinar is divided into three parts. The first will be a state of an evidence check, which is going to be provided by the wonderful Clare Rushton. We'll then be joined by Bob and Carol, a family with an adult child with long-term methamphetamine use disorder, who discuss their experiences, the positive and challenging aspects of navigating the AOD system as a family. And then in the final part, Claire's going to come back and we'll be joined by Professor Pete Kelly, Elizabeth Stubbs, Belinda Volkov, and Jessie Winhausen, who collectively there's around 100 years of experience in the room. So that's pretty awesome. I just want to point out, if you've never been in a Zoom webinar before, just that there's a Q&A feature at the bottom of in the menu bar there. Please feel free to use it at any point, because there will be a chance for the panel to discuss, answer any questions you have, or for you to weigh in on any of the topics that we're sort of talking about. So without further ado, I'm going to introduce Claire. Claire is a psychologist, clinical registrar, working at Hunter Primary Care. She's providing psychological therapy to adults and young people with a range of mental health difficulties, including alcohol or other drugs, mood disorders, trauma, and interpersonal difficulties. Claire is completing her PhD at the University of Wollongong, and her research is investigating the experiences of people who were affected by a loved one's alcohol or other drug use, and how to effectively address their needs through the intersection of research and clinical practice. So I'll hand over to Claire.
Thanks for the introduction, Dora. I'll just share my screen. Does it come up all right on your end?
Yeah, all good. Thanks, Claire.
Perfect. So thanks again for the introduction. And today, as Dora mentioned, I'm going to be presenting a bit of an overview of the research in this area. So before I start, I'd also like to acknowledge the traditional custodians of the lands that we're all meeting on today, and pay my respect to anybody, any Aboriginal or Torres Strait Islander people who are in attendance right now as well. So here's a photo of where I'm actually zooming in from. So I'm lucky enough to be on the beautiful lands of the Awabakal and Warramai people up in Newcastle. So I'd also like to acknowledge the people who have lived experience of mental health and alcohol and other drug issues in this area, and specifically the families that have really contributed to the research that I'm going to be talking about today. So this is just a bit of an overview of where we'll be going in this brief presentation today. So to start with, I'm going to be summarising the research that exists at the moment that's looking at families and methamphetamine use, really looking at where we're up to. And then I'll also be touching on some questions around where this research area might be headed. So as Dora just highlighted, methamphetamine, as we know, is a global concern, and we actually have some of the highest usage rates here in Australia. So according to the AIHW data, around 1% of the Australian population have used methamphetamine in the last year. And there are particularly high rates seen among marginalised communities. So we see ice being over 2 times as prevalent among Aboriginal and Torres Strait Islander people, and over 5 times as prevalent among the LGBTQ community, which again is really, really concerning when we look at those statistics. So drug use impacts not only the person that's using the drug, but it also has substantial impacts to their family, their friends, their significant others, even parents, grandparents, all these people in that direct sort of network surrounding that person. So from here on, I'll be referring to that group just by the word families. So in Australia, we don't really have a lot of data on just how many people are affected. But if we kind of think about that last slide I just showed, we can really extrapolate on that when we look at the usage in the last year. So that's 1 in 100 people who are using regularly. And think about around each of those people, we're going to have maybe 1, 2, up to 6 people that you can kind of think about as in that direct immediate network. So families affected by a loved one's drug use experience high levels of stress, anxiety, depression, relationship breakdowns, and grief around the expectations that they held for their loved one's future. So methamphetamine use also brings quite unique challenges due to the illicit nature of the drug and its high potency. And this really includes stress around their loved one's unpredictable behaviour, involvement with the criminal justice system. We see a lot of financial strain and this real fear for the safety of both the person that's using the drug, but also for the entire family system. So there's been a lot of stigma and negative attitudes around drug use, and the family's role has really, and this has really limited sort of the accessibility of support services. And what we do see is this stigma and kind of societal attitudes then become internalised among family members, and this becomes kind of shame, which we really know impacts their help-seeking behaviour as well. So despite these harms being quite well known, her families have generally been quite an under-researched population. And I guess more recently, we're kind of becoming more aware that families can actually play a really important role in the treatment of the person that's using methamphetamines. And also just an awareness that families actually just require some support in their own right. So on this, we conducted a systematic review just to see how many kind of studies they were looking at the effectiveness of interventions for families that were affected by alcohol or other drugs. And we found that of the studies that we found, there were improvements in family members' depression, distress, and coping. And this was seen among both treatments that were delivered in a one-on-one setting, but also in group-delivered treatments, which is really promising. So in 2014, the Victorian ICE action plan identified that families were a really at-risk group and that they really needed a lot more funding and a lot more support available to them. But it's interesting, there hasn't been a lot of research that's actually looked at families specifically who are affected by methamphetamine use. So there was a review here that you can see that was published in 2022, and this looked at interventions for families affected by methamphetamine. And they found, they summarised 4 qualitative studies that you can see on the left side here. And that really just described the family's experience. And they found families were experiencing a lot of emotional distress, concerns around disruptions to the family, financial difficulties, as I highlighted earlier, and this real difficulty in balancing kind of the needs of supporting their loved one, but also protecting the family unit. So that was a really kind of difficult balance. So they found only 2 quantitative sort of intervention studies, which looked at treatments related to families. And of these, one of them was conducted in Iran and the other one was conducted in Australia. And the studies really found that acknowledging families' concerns, providing information to families and enhancing their problem-solving skills to be really key elements of that treatment. So also interestingly, in the last couple of years since that review was done, there's been quite a few studies that have come out, and the majority of these have actually been done in Australia. So we really seem to be leading the way in this area. So 2 of these studies looked at treatments for families, and these were both feasibility trials with fairly small sample sizes. So I'll be speaking to one of these more. I was actually involved in this study on the right here. And this trial was funded by NCRED and looked at the feasibility of Smart Recovery's Family and Friends program. And this was for people who were affected by someone's methamphetamine use. And this program was actually delivered online, so via video conferencing like we are today, during the pandemic. So Smart Family and Friends is an 8-module group based on cognitive behaviour therapy principles, and it's got a really strong focus on harm reduction. So for this trial, we had 45 participants who were involved in the study. The majority of them identified as females over 50 years, and they were the parents of an adult child that was using methamphetamine. And that seems to be fairly representative of the research that's been done in this group. So I thought this was really interesting as well. The average duration of their loved one's drug use was around 11.6 years, so a really long amount of time that these people are having these difficulties. And the results of this trial showed that the program seemed to be really feasible. We saw really good attendance rates, high satisfaction with the program, and participants reported reductions in distress, burden, and also improved coping after they participated in the trial. So we also did some interviews with participants once they'd gone through the program, just to find out what they really liked about it. And one thing that kept being highlighted was the benefit of that mutual support element. So being in a group and being able to share their story with other people that actually just understood their situation. Mm-hmm. So they've also been, so since 2022, since that review was done, there's been quite a few qualitative studies that have come out as well. And these qualitative studies are really valuable in this space because they really just help to tell the story of what it's like to be a family member. So this first one I want to highlight was conducted in WA, this study up here. And what they did a longitudinal study. So they took, I think, 2 time points. And they found out that family members' approach towards their loved one that's using methamphetamine seems to sort of change and adapt over time. And they seem to find a fairly common pattern of moving from attempting to fix the situation and needing that really clear answer to then stepping back and actually seeking support for themselves, and specifically from people that they believed to be in a similar place who would really understand what they were going through. So another recent study describes some key themes around sort of families' experience of stigma, the ways that they've been coping, and that value of sharing those personal stories again. And they also highlighted this experience that families have of what's called disenfranchised grief. And this is when the grief is, if someone's experience of grief or loss is really invalidated by social norms, and which we know that stigma around the drug use can lead to families having real difficulty sharing their pain and their grief with others. And this can lead to feelings of isolation. And the final study I want to mention here was actually looking at the training needs of alcohol and other drug helplines around Australia. And the study identified a need to provide more support and training to helpline staff around working with families of people who use methamphetamine, which we know is a really kind of key group that are seeking that information. So where to next? So historically, research has really focused on the ways to work with family to encourage them either into treatment or really highlighting the benefits of families' involvement in treatment for the person that's using drug use. So really looking at outcomes around reductions in use or abstinence. So there is a little bit of research coming out around families and looking at their needs as a population in their own right. But this has taken a largely deficit approach. So looking at the way that they are impacted and those kind of negative outcomes for families. So I think moving forward, it's going to be quite important to start to really balance these perspectives out by just highlighting the experiences of families as a population in their own right. And this is something I think I've been thinking about a bit through my clinical work as well, just that importance of really meeting somebody where they're at in the moment. And as we know, families, as people who use drugs, they're on a journey and we don't know the timeline of that journey. We don't know the ups and downs that have led them to the place where they are in that moment of seeking help. And I think the research that I'm particularly interested in is starting to honour family strengths and any existing strategies that they've actually got to lean on in that moment. And also understanding areas that they might need some further support or any specific needs they might have, again, in that current stage in their journey. So I'm currently involved in a few projects. So we're currently recruiting participants for the Family and Friends survey, which you can see on the left here. So this is aimed at really building that understanding of the experiences of people in Australia who are affected by someone else's alcohol or other drug use. And we're really interested in outcomes around, I guess, firstly, kind of burden and stigma and those kind of understanding the difficulties they're having, but also looking at factors like resilience, social connection and social isolation, looking at those help-seeking behaviours and also attitudes towards help-seeking. So currently we've got data from around 100, I think we're up to 144 families who are affected by methamphetamine. So keep an eye out for that research over the coming months. So I've also been working on a qualitative paper, and this has been looking at those family resilience processes and kind of the adaptations that we're seeing families making in the face of the stress that they're experiencing. So another project that's happening at the moment in this space, so Julie Perrin from the Karuna Centre, Paige Webb and myself have started a group called the Families and Alcohol and Other Drug Research Network. And this is really a network for clinicians, for practitioners, service providers, researchers in the AOD sector. And we have, at this stage, we've got meetings, I think, every quarter, and they usually involve a presentation and a discussion. And it's a really great opportunity. I think it's been really helpful for all of us that have been involved to find out what is actually going on in this space around Australia. And some of the topics that have been raised that we've spoken about include how can we best measure outcomes for families? Also looking at different ways that different populations within this group are accessing support and treatment. And how can we start to provide more support to remote and regional communities as well? So we're hoping, kind of in the stage at the moment of putting together a bit of a resource library. So if you'd like to be involved or come along to any of these meetings, just feel free to reach out. There's my email there, or get in touch at some point if you'd just like to talk about it further. So to finish up, I might just leave you with some resources for families that I've come across that have been somewhat helpful. So we've got some fact sheets that have come from Inside in Queensland, some really good resources there. Breakthrough is a really great organisation. They've got some methamphetamine specific information and resources for families, and some more general ones as well, just around kind of supporting someone that is in addiction. There's also some great resources. This one here is a video that was put together by New South Wales Health down in the Illawarra region. And it's a really nice resource that can be helpful just to help families understand that they're not alone in what they're going through. This Tools for Change, which is designed by NADA as well, has been really, really good to have a look at if you're interested. And we've got a few other resources here as well. And I can put the links up to those papers that I mentioned earlier in the chat. Right, so any questions or anything at this stage?
Thanks so much, Claire. It's really awesome to see the work that you've already done and the work that's on the horizon. And we'll really look forward to getting you back once all of those studies are completed to provide the next instalment, especially the large survey. It just sounds like there's so much interesting and very, very necessary data to provide and speak into this conversation. I just want to remind everyone about the Q&A feature. Please feel free to jump in there and share your thoughts, opinions even, or ask a question, because we definitely want to hear from you. Thanks so much, Claire. So we're really fortunate today to be joined by Bob and Carol. Bob and Carol have an adult daughter who has experienced methamphetamine use issues. And as a family, they've been navigating the health system, looking for the right care for their daughter and for themselves over a period of several years. So thanks again for joining us, Bob and Carol. I know that your mic is not muted, so that's really, that's great. We can charge ahead with that. And so, I mean, we just listened to Claire outline all of the current evidence and stuff like that. Did any of that sort of relate to you guys or feel relevant?
Yes, it certainly did. It did highlight, and it summarised, like all the problems that we've had over the years with our daughter and with the
health system.
with the experiences that we've had with her addictions. And Carol and I are in our 80s now, and we've been we've had this problem for over 30 years, so it has had a very significant and long-lasting effect on our life and health and our mental our mental well-being and so on. And our daughter sort of left home at an early age. She was only 18 when she left, and she was because she was 18, there was nothing much that we could do to stop her from leaving home. She was at the legal age to leave, and so we just had to allow her to leave home, and she moved over with a partner, and it wasn't long before she fell pregnant and had children, and then not long after that we found out that she was taking drugs, and
he was too,
the partner, and it had a like a very vast strain on Carol and I's relationship, and knowing where to go, what to do, how to help. And
but we got a call to say that he was in a very bad way with drugs, and so Bob went over there and packed up and brought the children back to Sydney, and she lived with us for 12 months. And in the meantime, she met another guy also doing drugs, and she left home and took the children with her. They didn't live very far away from us, so I used to attend all the children's schooling functions. I used to take the children to sport, and she did hide the drug taking from the children. I will say she was a good mother to them, and they were well fed and looked after. But the drugs seemed to escalate, didn't they?
yes, they did.
And
when she was living with us at home, we went through all the normal drug addiction problems of our daughter stealing and lying and all those sort of negative things, which were
straining,
very straining on our well-being and so on.
So she was having all this paranoia, and we took her down to the hospital, and they admitted her for 5 days, I think it was. And we wanted to talk to the doctors. We asked the doctors, could they ring us and what we could do, and they never rang back. We never got any feedback or anything. And then we went to the hospital again and had a counsellor who was very good, and she put us on to another counsellor that looks after families' well-being, and that has been tremendous for Bob and I, because he gave us a book which had a 5-step program, and we were able to talk to the counsellor about how we felt and where to go for help. And because Bob and I could never talk about to any of our friends or family about drug taking, and so it was all kept internally. But then the counsellor got her into this detox and going to for rehab for 10 weeks. And that has been absolutely wonderful.
Yes, so far, yes, it appears that
changes in her.
Seems to be clean for, well, it's only been a short time, but anyway, she appears to be clean. Like she was addicted to drugs, alcohol, and cigarettes, and since being out of rehab, she doesn't seem to be smoking or drinking, and so that has been, one of the best things that that have helped Carol and I to for this treatment that she's had. And
we've sent her. She's gone over. She has a very close friend in, and to get away from all those people that were she was doing drugs with. She's over there with a friend, and she's over there for 3 weeks. So hopefully, and her friend is going, any problem, she's going to ring us and we'll deal with the problem if it occurs. But she's also got some help from that they're going to get a TAFE course organised for her, and another, and
do volunteer work.
Help her to get into some volunteer work.
She needs to keep occupied. We need to find things to
keep her occupied.
And then, this was part of what we learned from the 5-step course that we did with Jesse. And
he was great. Absolutely wonderful.
Yes, and we found that talking to people like Jesse about our problems, it was very helpful to Carol and I to relieve our stress levels and just get some help in knowing where to go to get further help. So we think that the 5-step program was very, very good, and we would recommend it to anyone in our situation. And
it's been good with all the tools that they've given. Lots of tools.
Has been to the mental hospital several times, and she goes in for 4 or 5 days, and she's out, and within a short time she's back into the drugs, and so I don't think there's enough follow-up from those sort of hospital, the mental health hospital treatments. We tried to get to talk to doctors about this condition and how we could help, but we never did.
Never got any follow back. We left messages with nurses and could the doctor ring, but never got any feedback.
So it sounds like a really big point of difference when you started working with Jessie was around, I guess, just being heard, and then being provided resources which helped you along the way. Would that be fair? There's just a question in the chat for you from April. And April has said, thanks for sharing your story, Bob and Carol. It's wonderful that you both had support for you and someone to talk to. What would you say to other parents struggling about engaging in a 5-step program? So if there were other parents, go on.
Yes,
do it. It really is help. And we had a book, and we could put down our feelings, how we were feeling at the time. And that was good too, to get it all out from inside, to think about it
deeply, and
and it was just talking to Jessie, who listened very patiently and gave us some advice where to look. And that was the big turnover for us.
We kept it to ourselves for many, many years. We were ashamed of it and embarrassed, and so we never talked to any of our friends about it. But after the help that we got from the 5-step program and Jessie, we were able to
We've spoken
Yeah.
to a couple of friends
A
about
few
it.
friends and
Yes, so
close relatives about it, and it has
it has helped.
opened the doors a bit and helped us mentally cope with the situation.
And I think too, people were amazed because she could function. You would not know
No,
she was on drugs. You would not know. And that was the most amazing thing that, we didn't know for quite a while, did we? That she was on the drugs, but she could function
Yes.
and
Yeah,
it
it
just
was,
amazed us. And they were amazed too when we, said to these couple of friends, they said, oh, we never would have known.
but she would get like bad and go into
Like,
psychosis sort of, and that's when we had to have her admitted to mental health hospitals. So anyway, she's had her 10 weeks, and that seems to be of great help to her and
to us.
to us, yes, to us, yes, in particular, I guess. And we just hope that the treatment lasts and she's over it.
Thank you so much, Bob and Carol, for sharing your story with us. It sounds, I can, linking this back to what Claire just presented around the evidence, I can hear that narrative of grief and fear and also just how transformative the right kind of care and support, the right listening and the right resources at the right time can be. So I think it's a really good time now to bring in the rest of our panel. And I just want to say, Bob and Carol, that there's several thank yous for you in the Q&A there, where people are very appreciative for you taking the time to join us and share your story, which I think echoes many stories of the like, and we just really appreciate your generosity in your time and your experience with us. So I'm just going to bring in, thank you. I'm going to bring in the rest of our panel here. So we're joined by Professor Pete Kelly. Pete is a Professor of Clinical Psychology at UOW. He's the Acting Executive Dean for the Faculty of Arts, Social Sciences and Humanities. His research is focused on the development, implementation and evaluation of evidence-based approaches within mental health and substance use settings. We've also got Elizabeth Stubbs. Elizabeth has worked in senior management positions in the AOD and community services sector and has extensive experience in the development, implementation, delivery and review of youth AOD programs in the Northern Territory. Elizabeth has been a member of the NHMRC Consensus Committee, who developed the clinical guidelines in VSU, involved in the review of VSU and AOD sections of the CARPA Health Manual, and a contributing author for the Handbook of Aboriginal Alcohol and Other Drug Work, among other expert knowledge projects. Elizabeth has a Bachelor in Behavioural Science and certificates in AOD and Community Services. Elizabeth is the current Director of Sandpalm Consulting and the Acting CEO of CAPS Aboriginal Corporation. We've also got Belinda Volkov. Belinda is the Clinical Director at the Sydney Drug Education and Counselling Centre. Belinda has over 25 years' experience providing treatment for young people and their families who present with co-occurring substance use and mental health. Belinda holds a Master of Social Science in Addiction, as well as a Master of Social Work, and is passionate about social justice, harm reduction and advocacy for young people. We've also got Jessie Winhausen. Jessie is a psychologist and team lead at the Burton Street Centre Youth and Family AOD Service at St Vincent's Hospital. Jessie has over 10 years' experience working with families and young people impacted by trauma, mental health and substance use. Jessie also has completed a research master's degree from New York University in social psychology, specialising in political psychology. So I'll get you guys to unmute if that's okay. And so I might just sort of start by also just reminding all of the audience participants that they're to jump on the Q&A. This is the time. I think I mentioned earlier that there's a collective kind of more than 100 years of experience in this panel and covering, half of the country. And so I think, it's a really excellent opportunity to jump in on the conversation. And so I think I might kind of start just with a general question, and I might sort of direct this one at you, Pete, just around, are the needs of families with methamphetamine use disorders different from that of the needs of families who are going through other substance, for instance, alcohol or cannabis use disorders? are they different? And if so, how?
Good question. Good question. I should just acknowledge I'm on Dharawal country down in Wollongong as well, and thanks for inviting me. A bit of both. I think there's similarities and differences. I thought Clare did a really nice job in her presentation of highlighting some of those issues. So some of the similarities are around emotional distress, concern for loved ones, disruptions to the family unit, just the impact on the family. Likewise, just listening to Bob and Carol, it's common for people to use multiple substances. Often it's not that common for people just to use one single substance. And likewise, it's really common for people to experience both substance use issues and a range of other mental health or even physical health issues. So there's a lot of similarities. I think as Clare was talking about in terms of some of those qualitative studies, perhaps that there's some unique experiences for family members or friends or loved ones who are looking out for someone who's using methamphetamine. So the patterns of use and some of the ups and downs and perhaps a bit sort of an erratic lifestyle might be a bit unique to methamphetamine in some ways. Likewise, the stigma that Bob and Carol and Clare were talking about, very real and incredibly real. So there are similarities, there are differences. I think maybe the bigger thing to think about is, are the needs of family members who are impacted by another one's substance use, are they being met? And unfortunately, in drug and alcohol treatment, there isn't a one-size-fits-all approach. And so I think thinking about how we can help overcome some of that stigma and encourage people to access treatment and trying to personalize and tailor it as much as we can. So I think there's room for having specific methamphetamine research and treatment, and likewise people may benefit from broader treatment depending on their own circumstance. So sorry, I sat on the fence on that answer.
Classic research tactic there, Pete.
Yeah, it was.
No, that's really great. I mean, sort of thinking back to my own experience working with families, I was working in youth AOD and started doing family work through osmosis just through doing that work. And something that I personally found was that the toolkit that I had to do youth AOD work was like a very different kind of toolkit to work with the families and the parents of the young people who were going through that. And what I sort of found personally was that it was kind of more of a grief model, and there was more of like sort of being able to sit with somebody and validate their experience, and also provide strategies around kind of building self-care and things like that in the face of really, really trying circumstances. And as similarly to what Bob and Carol said, if someone's over 18, they're old enough to make their own choices. You can't put an ankle tag on someone and force them to stay at home and things like that. So I might sort of direct this question over to Jessie, just given as well that you were the one who provided the 5-step book and things like that for Bob and Carol. What would you say are the different sorts of skills needed to work with families? How would that sort of differ from the normal AOD toolkit? Yeah.
Sure. Thanks, Laura. And I'll just say I'm on Gadigal land in Sydney. Thinking about this, there's a lot in common. Obviously, the sort of the counselling skills, just the basic stuff around empathy, building trust, all of those micro skills are going to be the same. Whoever you're working with. The psychoeducation, often around substance use, around mental health, also. There'll be a lot in common there. With I was thinking about talking about harm reduction and how we talk about that, and that's very different. I've found that's very different because often with clients who are using substances, they'll find talking about harm reduction is a real relief, when you bring that up and you explain what that means, and if you're working from that model, because they're hearing that you're not going to tell them that they need to stop, or you're not there to tell them what their goals should be in terms of their substance use. Whereas with parents or other family, they can find that very challenging to hear that that's not what you think their loved one needs, whereas they may have very strong feelings about that they should be abstinent, but that's not where most of us are coming from. I think also there's ambivalence. There's certainly ambivalence in both, working with both, but a different type of ambivalence. You know, we know about ambivalence with people who are using substances around the difficulties they have. They may have goals, but the difficulties they have achieving them. Whereas, you know, ambivalence with family is often about, you know, protecting the young person or protecting the person who's using, and protecting themselves and their family. You know, there's that kind of ambivalence. But I agree that, yeah, grief is probably the biggest difference. I mean, you can apply grief to people who are using themselves because they have grief around their expectations of their own life and things that they haven't, you know, been able to see, to achieve or to see for themselves. But certainly, yeah, with families, I think that's a huge theme in with 5-step method in particular. There's a lot of work around acceptance, however that may, you know, look for different people. But that's also, and that's connected to the grief, you know, in a way that's about dealing with that grief. Yeah, and I think that parents or family, one particular difference I've seen is they'll often come and say, "What should I do? Like, what do I do in this situation?" You know, and so trying to move that to, yeah, how do I apply my knowledge and strengths and values, which I think is very, very important, the role of values. So how do I apply all that to this situation? How do I make the most out of this terrible situation, salvage some positivity and meaning, and not get, you know, swallowed up by this chaos and this grief. Yeah, so yeah, a lot in common and some differences too. Yeah.
Thanks for that. Beautifully answered, Jessie. Did anyone else want to weigh in on that? I could see a lot of nods in the panelists group, and feel free if anyone else had anything to sort of say on that.
I think it was just really around, I mean, just echoing what Jessie said, and, you know, it's delightful to do this because we've been in this space working for over 20 years and we're finally getting parents on the agenda. And I think, you know, even just to add to what Jessie was saying, you know, the stigma and the fact that as a society, we haven't reached the maturity to treat this as a empathic public health issue as opposed to a morality, criminal justice issue. So, very long time too, you know, parents have been hidden from services. So even for us as a service, you know, you're funded for the person with the drug problem, so you can't work with the families, even though the evidence is very clear that parents are the most underutilized resource for the person that's actually experiencing substance use. What happens though is that they have the same rhetoric as a lot of people do around, you know, sometimes it's a disease, we've got to first force a person into treatment. They watch intervention programs from America and think that's what we do. There's a lot of scope for community understanding that drug use doesn't happen to a person, it happens to a family. And grief are two of the most highly presenting things that we have in the room.
I think that's a really good segue to a question in the chat here, where somebody has asked or stated and then asked, there's a tension point between telling a family that their priority should be to look after themselves and build that sort of self-resilience and things like that, but then insisting that their support of their person can be what makes all of the difference. And then the system itself being such that it's nearly impossible to navigate for someone, for instance, with psychosis. Can anyone on the panel comment on how we can support families in this tension point between being, you know, so key and so necessary in being a support or, you know, a very important resource to a young person or a family member going through substance methamphetamine dependence or methamphetamine use issues, but then also being in a position of needing to kind of take good care of themselves and be rolling with some really, really turbulent stuff at times. Anyone want to have a go?
I think just on that, and I'm keen to know what Jessie and Matt say as well, but Now, when parents present to the service, quite often the parents and families will present before the person with substance use does. And that is an incredibly huge opportunity to look at stabilising the family first. You know, if the plane's going down and your mask isn't on, that is absolutely exhausting. And by the time they come in, they're exhausted by the system. It's almost systemic abuse. I don't want to be too capitalist about it, but it's like a systemic kind of abuse that happens, not intentional, but half of our work, and I reckon Jessie would be the same, is helping families, besides all the stuff that Jessie said, navigating systems that are quite inadequate. So because people think, well, if my young person is unwell and acutely unwell, I'll take them to hospital. Well, hospitals can be very clear about how acute it needs to be. And if it's drug and alcohol, it's a drug problem and they're released. So navigating the system for the parents, I think it's very important that workers validate before going into problem solving, because we have at risk of setting people up for failure. So that really strong level of validation and talking very openly and transparently with them that what they might need may actually not exist. And we don't want to set them up for failure and disempower them. So we want to work with what is actually in their control. They will always come in, and I'm generalizing, with the idea of only being in treatment to fix the other person, because understandably their priority is about safety. And what they learn is they learn that by looking after themselves, that gives them some distance to start to think about. And that's what Bob and Carol said so beautifully, was to have some space to even be able to think, to look at things through a different lens is pretty vital.
Yeah, and I might just say something directly about that question as well, because I think it's a fantastic question. I think maybe just almost paraphrasing a bit of 5-step method here, that there's a stance of sort of availability that parents and family can have, that you know, I think that what we often see is this binary between, I'm going to throw myself at this problem and I'm going to do everything I can to fix it, and that doesn't work, and then I'm going to reject. You know, I'm going to reject the person and I'm going to kick them out, or so it's finding a middle ground between those two. It's some acceptance. I think availability to the person. So it's not a rejection, but it's not. I'm here to fix everything.
Something about healthy boundaries or something like that, rather than I'm not rejecting you, but I also need to sort of say I can't give you any more money, or I can't put up with whatever's going on. It's harming me as well.
Yeah, 100%.
There's a question, and it was directed at Claire in the chat, and it says, is there much integration between the treatment and care that a person who uses meth receives versus the support that families get? It seems like they are two separate service systems. Or services. So I'll direct that at Claire because that's who it was directed at, but I'll invite anyone to weigh in on that, just around integration between the sort of individual support system versus the family support system, which seem to kind of be their own little silos.
Thanks, Sarah. Yeah, I think it's a really good question. I think maybe Belinda and Jessie can speak to this better than I can. But I think something that's really come out of the discussion that's happening right now is absolutely what Jessie and Belinda have highlighted around that need to, I think that oxygen mask analogy is just so important, that you can't, it's a cliche, but you can't pour from an empty cup. And if you are burnt out and going down, you're not really good to anybody, not to yourself, not to your person, not to the family system. And so again, kind of, I think there's some different systems that are set up in different parts of Australia at the moment. And as I said, people that are directly involved in those will kind of be the expert in that. But thinking about when we're moving forward, prioritising a need to balance both of those things and having a really clear linkage and pathway between them, because families are going to be coming in to seek help at all different stages of the journey. Some people might have only just found out and are in that sort of panic, kind of clinging to the life raft stage, whereas others, as I think we saw in that Smart Family and Friends trial, 11 years on average that they've been sitting with this. And I think the needs that they're going to be presenting with are very different, but the need to look after themselves doesn't change throughout that.
Belinda, did you want to add something into that?
No, not right off the top of my head.
Cool. No, fair
Um,
enough. I wasn't sure if that was a thinking face or I'm ready to speak face, but
I'm very animated, aren't I? I've got to be mindful of that. I just think, you know, that what's really kind of great about having these forums and these discussions is that they haven't been at the forefront of treatment. And it is a really necessary part. When you're talking about them being siloed into different services, I think there's been a natural inclination for that because the sector itself, I know in my nearly 30 years, it's changed and grown so much and so much change in that time. And even though the evidence is very clear that working with families and supporting them, the evidence that is available, I might say, really does show, and it makes sense that working with the family is there. I think for parents, it is very important that that lived experience voice that Bob and Carol really kind of paved that forefront, because I still think that we have a big gap in the capacity of workers being able to provide that service. So you're not doing family therapy, you're almost doing backseat family therapy. Like there's this kind of different way that you're working. And I think there's a really positive opportunity of workers who are experienced and researchers and people like Bob and Carol. And I've had the privilege of working with people like Bob and Carol and have so much respect for their journey. But the fact that we're now looking at this, where do we go in terms of also building capacity for access for those is another area, another talk.
I want to bring Elizabeth into this conversation. I think that, so a lot of what has been presented today is very much, I guess, pitched in a sort of Eurocentric Western kind of starting point, and even discussions around kind of the inclusion of family into a person's own therapeutic journey. I know that we, you know, in the 7 minutes we've got left, that's definitely not enough to even touch the sides on the reality of what that is for First Nations people. But would you mind speaking into some of that from your perspective?
Absolutely. I think there's some key things that we need to consider here when we're talking about supporting Aboriginal families. One of the things is we need to recognise that many Aboriginal families are already themselves experiencing particularly poor social emotional wellbeing outcomes. So there'll be current and historical trauma, there'll be, you know, socioeconomic issues. There's going to be a lot going on for these families. So sometimes their capacity to support their loved one is quite low. The other thing that I think is that we have to acknowledge that as a population, we have perspectives that are collective rather than individual. So I think when we talk about also the kinship systems, it's not likely to be just direct family members involved. It's going to be people that are influential through the kinship system. And so it's about not assuming that these are going to be the key people, the key family members, actually exploring that with the person. Who are those people who have, you know, even cultural authority, because that's quite important as well, bringing into those conversations, and are they willing to support their journey of treatment, but also how do we support them as family members. I think one of the things that I cannot highlight enough is that when we're working with our people, we need to do that from an Aboriginal worldview perspective. We need to use appropriate tools. We need to have appropriate understanding of the perspective. So for too long, our people have been expected to fit into that, you know, those sort of Western views and tools and therapies. But we've come so far in the research in the AOD space around supporting Aboriginal people, Aboriginal families, Aboriginal communities, and there's a lot of valuable resources that have been developed and that are out there.
Is that sort of, for instance, like the social and emotional wellbeing principles? Is that like some of the stuff that you're talking about?
Yeah, absolutely. So when we look at that, what we call the Sue Wheel, for those of you, most people are familiar with that now, you know, from start to finish, when you're working with not just the individual but families, that can actually guide assessment. that can actually guide how you support people in those different areas to support their loved ones. And I think, also I'm talking about tools. There's lots of tools in the AOD space that provide information to Aboriginal people, because part of this is supporting families, but also providing, factual and information. So, sometimes the stuff that we give in mainstream isn't appropriate and isn't digestible. So there's lots of resources, for instance, that particularly in the Northern Territory, we have quite a few resources that are developed by Menzies School of Health and Research that are appropriate for Aboriginal people. So Emerging Minds does a really good job of developing resources as well. So yeah, it just needs to be more appropriate for the families and people that you're supporting.
Thank you, everyone. I'm just looking at the time, and we're coming up to our hour, unfortunately. I just wanted to sort of end with, I guess, a bit of a round table or a free, and kind of, what would you, in sort of summarising this, what do you think the sort of zoomed out needs, priorities of the system, the structure that's trying to, have these conversations and commence this work and start being a more family responsive system? What would you sort of say as just a few concluding remarks? And I might just start with, Pete, I guess I'll just go around from who I can see first, if you want.
Yeah, look, I think Belinda's been making the point, but I think it's sort of been too long to get this on the agenda. I think there's pretty good recognition at government level and service providers in terms of the needs of addressing the families. It's just a matter of making sure that there's enough services and there's enough, that things are in place to be able to sufficiently do that. I think what Jessie was highlighting, this is specialised work. I think Josie, I don't think we're going to get a chance to answer her question, but her question talks to the complexity of this work and the difficulty that it's involved. And so for Josie and for people like that, we want to make sure that there are services and there are places that they can access and get appropriate support. They're really difficult things to resolve.
I'll pivot then to Belinda, just next on my screen.
Yeah, I mean, I could absolutely echo what Pete's saying. I think there's been frustration from families and communities and people who've been on the front line for a long time, seeing those needs being met. And I guess, the word funding comes to mind constantly. And I think the other thing too is the capacity building. I think there's a confusion even in the language around what family inclusive or family work is, because people think of the traditional family therapy modality. And so we've got a lot to explore in that sense. But what we definitely know is that there is an absolute need. We don't advertise for the fear of not being able to handle the influx. We also work with young people. So there's some differences in working with families of young people, particularly when they're under 18 and it's not even an option to not have them in the home. So there's a lot of complexities, but we do need capacity building in our sector. We need to be, looking at all the different things, particularly what Elizabeth has mentioned is just so hugely important. But we need a lot of people to come together with that collective wisdom. So perhaps not being pitched against each other as NGOs for funding might be something to be really helpful in that area. So we can actually to the lived experience and have us inform the best treatments for families.
Thank you. Elizabeth?
Yeah, I think we definitely need to build capacity throughout the sector to supporting First Nations people, but we also have to look at access in remote locations where we know that even the individual themselves are experiencing, the substance issues don't have themselves a lot of access, and we know families have even less access in remote locations.
I'll go to Claire. Thank you.
I think something that just came to mind, some words while I was hearing everybody else summarise, was just trying to build a really flexible and compassionate approach, and that's through the systems, through the individual services. And it kind of comes back, I think Bob and Carol really touched on that when that doesn't happen, families are just meeting walls and don't know where to go next. And I think adapting that flexibility, and I think it's something we can all work on as individuals, but absolutely the systems need to really start adapting to that to move forward in this space.
A compassionate system, what a dream. And lastly, I'll just finish with Jessie. Thanks.
Thanks. Look, I think just specifically a bit about that flexibility. I look forward to there being thinking about Claire's presentation where there's the diagrams of the different types of parent support, you know, and I think they get a bit lumped together at the moment because there isn't that. But once there is that more capacity, being able to provide that specifically, what does this family need? Do they need support, you know, for themselves, or is it more that they need support helping get their, you know, loved one through the system or something like that? So I think thinking about that, yeah.
Excellent. Thank you so much, everyone. We're just a little bit over time, so I'll have to wrap up there. Thank you to our attendees. Thank you for coming. Thank you for being interested in this topic. Thanks for tuning in and listening to us. Thank you to all of our presenters, our panelists today. You guys are just awesome, and there's just so much wisdom and I don't know what to say, but just so much in it. And I think I'll be digesting this for several days to come. And big heartfelt thanks to Bob and Carol. Thank you for your generosity in sharing your story with us. Thank you for joining this professional forum with the view to help professionals to understand and respond better to family needs. And we really appreciate your generosity in coming forward and you know, yeah, sharing your story. So thank you so much, everyone. There's been a few comments around sharing the resources. So in the aftermath of this webinar, I'll summarise the resources that were mentioned throughout the webinar, and I'll put it into a sheet and I'll email it out to everyone who came. So thanks again, everybody. Please complete the survey so that we know if we're doing all right, or if you want other topics, help drive the webinar so that we're meeting your needs. And thank you. Thanks again, and I'll see you all next time.
Thanks, Dara.
Thank you.